Good afternoon to all of us, and a great welcome to this week's presentation on inflammatory bowel disease. Dr. Betty will be leading us in this week's presentation. It's good that we're looking at this because it's not all diarrhea that usually is as a result of immunosuppression. I remember back in practice in training in Kolebu, there was this patient that was referred to us from Tamale when I was doing gastroenterology sub-rotation. This patient has been going to several peripheral hospitals, and every time she goes, she runs diarrhea, and all the practitioners were doing or prescribers were doing were to keep testing her for HIV and diabetes, saying that even one of them actually wrote that suspected HIV, despite the fact that the HIV test was negative. They even go ahead to do the confirmatory test, which is negative. So we don't force diseases on people where they don't exist. And then inflammatory bowel diseases, especially ulcerative colitis and Crohn's disease, are things that are with us, especially like we'll be seeing in our presentation, talking about the microbiomes and alterations in them. So kindly stick and stay with us as we go through this presentation. And please take note of your questions. You can use the chat box and putting them in. And then hopefully in 30 minutes, we should be done with this to allow us to have a discussion around them. So kindly join me to welcome Dr. Betty. Dr. Betty, please take over. Thank you.
Good afternoon. Today we'll be discussing inflammatory bowel disease, and I'm in the person of Dr. Betty Posuglogyogluu. So this will be the outline of our presentation. So what is inflammatory bowel disease? It's nothing less but an idiopathic disease caused by a dysregulated immune response to the host intestinal microflora. So it's basically an immune-mediated chronic intestinal conditions, which comprises of ulcerative colitis and Crohn's disease. We'll discuss them further as we go on. We talk about the epidemiology. The incidence is high in northern countries such as United States, the UK, Norway, and Sweden. The number of individuals affected by IBD across the world increased from 3.7 million in 1990 to 6.8 million in 2017. In North America, the age standardized prevalence rate of IBD was 422 cases in 100,000 population. The incidence and prevalence of Crohn's disease and ulcerative colitis appear to be lower in Asia and in the Middle East. However, new studies have shown that newly industrialized countries in Africa, Asia, and South America have started having an increasing incidence in IBD. So IBD has a bimodal distribution in that the peak age of onset is around 15 to 30, and then the second peak around 50 to 80 years. It's per the sex is equal in both male and female, but some studies show that ulcerative colitis has a male predominance as compared to female, and Crohn's disease has a female predominance as compared to males. It's also common with respect to race in the Jewish population, and also it has a lower incidence in Hispanics and then Black populations as compared to white populations. When we talk about the risk factors, basically we talk about the genetic and environmental factors. There's a high risk or an increased risk with first degree relatives, up to 5 to 20-fold. That's father, mother, parents, brothers and sisters, and children. Also, it has been shown that twin studies has a concordance of about 70% in identical twins, and then 5 to 10% in non-identical twins. We talk about the environmental factors. We talk about the diet. It has been shown that high fiber diets decrease the risk of Crohn's disease, but not ulcerative colitis. It's also been shown that animal fats and then polyunsaturated fats also increase the risk of ulcerative colitis, its relapse, and as well as Crohn's disease. Vitamin D deficiency too is shown to increase the risk of IBD. Smoking, which is one of the environmental factors that has been widely discussed, has been shown to have a protective a protective factor. It's protective in ulcerative disease, but increases the risk in Crohn's disease. Infections such as Clostridium, Salmonella, and Campylobacter also cause, they lead to inappropriate immune responses. That also increases the risk of IBD. Oral contraceptives and hormonal replacement therapies also have been shown, because of their high levels of estrogen, to influence the incidence or the risk of IBD in patients. Physical activity has also been shown to be associated with a decreased risk of Crohn's disease, but not of ulcerative colitis. When we talk about the pathophysiology, it is not entirely understood, but what we do know is that when we in the gut, we have commensal bacteria on the surface of the mucus. We also have certain cells that help to sustain help to maintain an equilibrium in the activities of this bacteria. So when all these risk factors that we've mentioned, the genetic predisposition and then the environmental factors, cause a translocation of microbial products through the epithelium of the epithelium of the gut, this leads to an activation of immune response, where there are T cells that are activated, and these T cells in turn produce an activation of cytokines, and this in turn produces a response of TNFs and interleukins, and all these factors in turn cause tissue damage, and then gives us the symptoms that we have and then the complications of IBD. So cytokines which are released by macrophages in response to various antigenic stimuli bind to different receptors. These cytokines differentiate lymphocytes into different types of T cells. We have the T helper 1, which are principally associated with Crohn's disease, and T2 cells, which are principally associated with ulcerative colitis. So let's talk about ulcerative colitis. So it's an inflammation that begins in the rectum and extends proximally in an uninterrupted fashion. That's a continuous fashion to the proximal colon, and could eventually involve the entire length of the large intestine. This inflammation is limited to the mucosa and the submucosal layers. It does not extend into transmurally through the gut. So 40 to 50% of this pathology is limited to the rectum, and when it's like that, we call it proctitis, ulcerative proctitis, or end rectosigmoid, which is called a proctosigmoiditis. 30 to 40% are beyond the sigmoid, but do not involve the whole colon. They get to the splenic flexure, where we term them as left-sided colitis or distal colitis, and 20% involve the entire or the total colon, which is called a pancolitis. In ulcerative colitis too, we tend to see that the crypts are inflamed, what we call cryptitis, and then we have abscess forming there, which is very typical. In long-standing pancolitis, the bowel becomes shortened, and then we have pseudopolyps forming. Pseudopolyps are nothing but cells of the colon trying to regenerate, and that is how they tend to appear. When we talk about Crohn's disease, it affects any portion of the gastrointestinal tract from the mouth to the anus. It is transmural. That means it goes across the layers all the way to the muscularis layer. And it involves it is discontinuous. And that is, it has this fashion that we call skip lesions, where there are areas of areas that have the pathology and then areas that are having normal mucosa. The entire wall of the bowel is edematous and thickened, and then there are deep ulcers which often appear as linear fissures. Thus, the mucosa between them is described as a cobblestone appearance. So this is just a diagrammatic representation of the degree of involvement when it comes to ulcerative colitis, where we see when it involves the rectum or the rectum and the sigmoid, what is called, when it involves the whole descending colon and then the whole colon as a whole, the ascending and transverse as well. And then when it comes to Crohn's disease, the fact that it's mainly common in the ileal region or the ileocolic region. And then we can also find it in the small intestines, and then the whole of the colon in 20%, and it also involves the perianal regions. So you can also appreciate the fact that it is not in a continuous fashion when it comes to the Crohn's disease, but you see that there are areas of normal mucosa and the areas of so this is just another representation of how the mucosa is involved, and then the muscularis layer and all that. So in Crohn's disease, you can see a thickened edema of the mucosa wall. You can see that there can be abscesses that are formed. You can see the linear ulcerations, and it's not showing, but you can see the cobblestone appearances as well. When it comes to ulcerative colitis, you can see that there's thinning of the wall. The wall is depleted, and then there's crypt distortion, as well as the formation of pseudopolyps with the ulcerations. So when we talk about the clinical features, there are certain clinical features that are common to both. So one is diarrhea, which can be mucus or bloody in nature. There can also be constipation. So this may be a primary symptom in ulcerative colitis when the disease is limited to the rectum. Constipation may occur and may proceed to bowel obstruction. There's bowel movement abnormalities, pain or rectal bleeding may be present, as well as severe urgency and tenesmus. Abdominal cramping and pain is common in the right lower quadrant, which speaks more to Crohn's disease. There can also be pain around the periumbilical regions, and then pain at the left lower quadrant in moderate to severe ulcerative colitis. There can also be nausea and vomiting, which often occurs more in Crohn's disease than in ulcerative colitis. When it comes to each of them, there are some cardinal symptoms. So when we talk about the diarrhea, with like bloody diarrhea, it speaks more towards ulcerative colitis. So you have rectal bleeding with passage of mucus and bloody diarrhea. You also have the presentation which depends on the site and severity of the disease. The sites we already mentioned, it could be the rectum, the sigmoid, and so on and so forth. And then the presence of extraintestinal manifestations. So when it comes to ulcerative colitis, the first attack is usually more severe, and then it's followed by relapses and then remissions. So stress and emotional stress, infections, gastroenteritis, antibiotics, and then NSAID therapies may provoke relapses. But when we come to Crohn's disease, the major symptoms are abdominal pain and diarrhea, which is not usually bloody, not usually, but some can present with bloody diarrhea, which is not as significant as ulcerative colitis, and the presence of weight loss. There can also be the presence of perianal diseases such as anal fissures, anal fistulas, anal tags with rectal scarring, and then there can also be severe oral ulcerations. Here are some of the extraintestinal manifestations, and we should take note of these so that when we see clients presenting with any of these, we it should draw our attention to the fact that it can be either the patient is probably suffering from an IBD if it is isolated, or if the patient presents with some symptoms, the diarrhea, the cramping, and has any of these extraintestinal manifestations, it should draw our attention to IBD. Common ones are the arthralgia and then joint pains, which are very common, erythema nodosum, pyoderma, gangrenosum, amongst others. We also have others that are unrelated to IBD activity. So when we're trying to make a diagnosis of IBD, it would take into consideration the history, the physical examination, and then the investigation. The history, we already spoke about the signs and the symptoms and signs these patients will present. Then we come to the physical examination and then the investigations. So we come to physical examination, because it's an inflammatory process. Most of these patients can present with fever, can present with tachycardia, dehydration because of the chronic diarrhea they might be having, pallor. Those who are having bloody diarrhea, they'll be very pale. They might even be lethargic. They'll be wasted because of malabsorption, the fact that nutrients cannot be absorbed. You can also have oral apoptosis. It can be abdominal distension, tenderness, and a mass. There can be a palpable mass in the right lower quadrant, which is very common with Crohn's disease. There can also be perianal fissures, as well as fistulas, abscesses, or rectal prolapse. When you do a DRE, your examining glove would be stained with bloody stool. There can also be growth retardation, especially in the teenagers who develop it, or the young adults. When we come to the investigations, a full blood count is done. Full blood count will show us the level of blood loss, as in the HB, which will be low in patients who have bloody stools. Also, the WBC counts can also be high as well. LFTs will show us the albumin levels in these patients. We can also do the C protein, C-reactive protein, and the ESR, which are reactants of the active phase. Due to the fact that it's an inflammatory process, these values they will be found to be elevated. Serologic studies such as PANCA and perinuclear anti-neutrophil cytoplasmic antibodies, and then anti-sarcomatocytes, cerevisiae antibodies can also be done. A positive PANCA is more suggestive of an ulcerative colitis, and a positive ASCA is suggestive of a Crohn's disease. So do is 2 RE cultures to rule out any bacterial causes or protozoal causes of or infective causes of the diarrhea the patient might be presenting. Also, stool for occult blood would be necessary. Stool markers for inflammation, that is the fecal calprotectin, which is very, let me say, very specific, or yes, it helps to and when it's high, it shows that yes, there's an inflammatory process going on. So it speaks highly in favor of an IBD. Radiological investigations such as plain abdominal X-ray can be used to diagnose ulcerative colitis, where you see gross dilatation of the bowel. A barium flow through can also be done when you're suspecting Crohn's disease, where it helps you to see if there are strictures through the narrowing of the gut. You can also do an ultrasound scan. You can also do a CT enteropathy, magnetic resonance enteropathy as well. The gold standard is enterography, CT enterography, and then magnetic resonance enterography. Endoscopy or sigmoidoscopy or colonoscopy with a biopsy are the basics for our diagnosis. They are the gold standard in diagnosing an IBD. And then the capsule endoscopy as well can be done. It's non-invasive, and then it helps you to appreciate the bowel mucosa and then the defects or the tissue damages that can occur. So when we do an endoscopy, with respect to ulcerative colitis, you'll find that there's loss of the vascular pattern, granularity, there's friability, and there's contact bleeding with or without ulcerations. And then there's a continuous pseudo polyps, exudates, and edema as well. When it's Crohn's disease, you find patchy inflammation with aphthoid, linear or stellate ulcers. You also find strictures. You can also find perianal lesions, often with rectal sparing. And you can also appreciate the cobblestone appearance and then skip lesions with granulomas. When the biopsy is done with ulcerative colitis, you would find crypt abscess, you find crypt atrophy. You also find signs of inflammation and mucin depletion because the goblet cells are affected. With Crohn's disease, you find granulomas, non-caseating granulomas upon biopsy. Before you can treat, or you can, before you can treat or manage patient with IBD, there are certain criteria that are used to assess the disease severity. So this is a table showing us what we can use to assess the disease severity of our patients, if the patient has ulcerative colitis or if the patient has Crohn's disease. So with ulcerative colitis, we use the TrueLab with criteria for assessing the severity. So it takes into consideration the stool frequency, the pulse, the rectal bleeding, the hemoglobin levels, the weight loss or percentage of weight loss of this patient, the temperature, the ESR values, and then the albumin levels in this patient. And depending on what the patient presents or the values that we find during our physical examination and our lab investigations, we either classify them into mild, moderate, and severe, and this will help us in the treatment plan for these patients. Also, when you talk about Crohn's disease, we have a Crohn's disease activity index, which we can also use to assess the disease severity of these patients with its features or variables. And then depending on the values, we can also classify them into mild, moderate, and then severe. This is also another way of assessing disease severity, which is used in ulcerative colitis per endoscopy scoring system. It's called the Mayo endoscopic scoring system, where a score of 0 is normal or inactive disease, a score of 1 is mild disease with its features, a score of 2 is moderate disease with its features, and a score of 3 is severe disease with its features per endoscopy. So what are some of the differential diagnoses of IBD? So most of our differentials will either be from an infective cause or a non-infective cause. The infective causes such as our bacterial causes of diarrhea, Salmonella, Shigella, Campylobacter. Since we are in the TB endemic areas, we should consider abdominal TB as well. HIV/AIDS is also one of the factors we should consider as well, and then other protozoal causes. When it comes to the non-infective differentials, we have the celiac disease, the appendicitis, diverticulitis, irritable bowel syndrome, ischemic colitis, and NSAID-induced colitis. Most of these diseases, they are very close when it comes to the symptoms. So a close history, proper physical examination, and then investigation should help us differentiate one from the other. The complications. So severe life-threatening inflammation of the colon can, what we call toxic megalocolon, can occur in people with ulcerative colitis, and it is very, very severe. It can kill the patient, and then we should act appropriately. Perforations can also occur in the small intestines and in the colon. With either of them, the toxic megalocolon can perforate, or when we have fistulization, which is also a complication in Crohn's disease, can also lead to perforation. You can also have acute hemorrhage in Crohn's disease. You can have obstruction when there's fibrosis taking place, especially in Crohn's disease, where it's transmural, the mucosal, the muscular layer is involved, and this causes fibrosis and in turn causes scarring and then narrowing of the bowel, causing strictures. These strictures can lead to obstruction and can present as an acute abdomen. We also have our perianal or ischiorectal abscesses. Cancer, which can occur in patients who have long-standing colitis, more than 8 years of duration, and the malabsorption. So with respect to the management, our management is based on the aims of treating the acute attacks to prevent disease progression and prevent relapses as well as complications. We have a group of medications that we use in the management of IBD. And the first group is a 5-amino silates, that's 5-ASA group, which modulates cytokine release from the mucosa. Examples are mesalamine. Mesalamine, we have sulfa, salazine, balsalazide, and then we have the topical mesalamine as well. We also have our corticosteroids, which confer an anti-inflammatory function. We have our anti-TNF antibodies, which include the infliximab, adalimumab, and the rest. They basically suppress inflammation and induce apoptosis of inflammatory cells. We also have anti-integrins, which decrease the trafficking of circulating leukocytes. So they also reduce more or less the chronic inflammatory process. An example is vedolizumab. We also have the thiopurines, which include azathioprine, mercaptopurine. These are immunomodulation medications. So they do that by inducing T cell apoptosis. We also have methotrexate, which confers an anti-inflammatory function, as well as our antibiotics. Antidiarrheal agents, such as the loperamide 2, can be used. And then we have our diet, which is low in fermentable oligosaccharide, disaccharides, monosaccharides, and police, which is recommended in these patients. So when we come to the management of ulcerative colitis, as I said, after we have assessed to see the disease severity, if the patient is found in the group of mild to moderate ulcerative colitis, we normally use our topical mesalamine, which is administered as a suppository, 1 gram daily at bedtime for patients who have proctitis, or as an enema, which is 4 grams at bedtime for those with proctosigmoiditis for 4 to 8 weeks. We can also use our oral 5-ASA, that is mesalamine or balsalazide, 2 to 3 grams once daily in combination with a suppository before bedtime. And this is good for patients who have their disease extending above the sigmoid colon. You can also employ corticosteroid treatment in mild to moderate ulcerative colitis in patients whom 5-ASA therapy has failed or is not tolerated. Example is budesonide, which is 9 milligrams per day orally for 4 to 8 weeks. For moderate to severe ulcerative colitis, we start with our oral corticosteroids. That's prednisolone, 40 milligrams daily, and then we taper down over 6 to 8 weeks. You can also employ the anti-TNF antibodies, that's infliximab, 5 milligram per kg at weeks 0, 2, and 6. And then long-term maintenance of 5 to 10 milligrams per kg every 4 to 8 weeks. Anti-integrins are also used here if monotherapy is not working. You can add another therapy to make it 2. So you can use the vedolizumab induction of 300 milligram intravenously at 0, 2, and 6 weeks, and then long-term 300 milligrams intravenously every 8 weeks. When initiating induction therapy with anti-TNF agents, and then an immunomodulator can also be added. As I said, you can, if you don't want to do monotherapy, you can add another therapy, which could be any of these, the thiopurines or methotrexate. For acute severe ulcerative colitis, we should consider parenteral feeding, because most of these patients, they are usually not clinically stable enough to feed via the mouth. So what you have to do is to ensure that there's total parenteral feeding. You also restore circulating volume. If you have to transfuse, you transfuse. Correct electrolyte abnormalities as well. These patients too are at risk of venous and thromboembolism, so we give them prophylaxis as well. That's the drug therapy. We employ the corticosteroid therapy, that's IV methylprednisolone 40 to 60 milligrams daily. Hydrocortisone NMS 100 milligram may also be administered twice daily. And anti-TNF therapies are also used here, the infliximab 5 milligram per kg dose, and also cyclosporine, intravenous cyclosporine too can be used in addition to the anti-TNF therapies. Surgery should be considered. When these patients, you see them and then you assess and you realize that no, their condition is very severe and surgical consult is needed, you inform the surgical team so that they can also make their input. And if this patient is stable enough to go in for surgery, a subtotal colectomy or an allostomy, and an allostomy will be done for them. When it comes to the management of Crohn's disease, some of the things that we should consider is the general considerations that we outline include the age, and then the age of onset, and then the early need of corticosteroids, the presence of perianal diseases, stricturing diseases, and upper gastrointestinal involvement. We also consider the laboratory markers of severe inflammation, which can include low albumin or hemoglobin or high C-reactive protein. We also consider the endoscopic findings of deep ulcerations. Choice of therapy would depend on the disease severity, as we already said, and the patient's age and the comorbidities, as well as the patient's preference. So early introduction of the biologic agents or biologic therapy, which are the anti-TNF and then anti-integrins, should be strongly considered in patients who have moderate to severe disease, most especially those with risk factors for a progressive course. So if the patient is having a mild or low risk disease, the nutrition is very important, and the symptomatic treatment with loperamide, they're having diarrhea. You can also, the drug therapy, when it comes to the drug therapy, depending on the location, if it is in terminal ileum or ascending colon, we can use extended release budesonide 9 milligrams once daily for 8 weeks. If disease remission is achieved, we taper the medication over 2 weeks in increments of 3 milligrams, and then we observe patients. We can also use the 5 ASA agents. Then the formulations release mesalamine in the distal small intestines. These are trade names of some of the 5 ASA agents. And most often, these are the ones that are prescribed. So when we talk about a left-sided or diffuse colitis, we have the oral corticosteroids, that's prednisone or prednisolone, which can be used. An initial dose of 40 milligram once daily for 1 to 2 weeks, followed by followed in those who respond by gradual tapering of 5 to 10 milligrams per week over 48 weeks. Sulfasalazine at a dose of 1.5 to 3 grams orally is given twice daily, which appears to be effective in improving symptoms and inducing remission in diseases involving the colon, but not of the small intestines. For patients who respond, we can also use sulfasalazine 2 to 4 grams per day, may be continued for long-term management. But if they do not respond, you cannot go ahead and do this. For moderate to severe or high-risk Crohn's disease, we employ the use of corticosteroids, that's parenteral corticosteroids, methylprednisolone 40 to 60 milligrams daily, outpatients with oral prednisone or methylprednisolone 40 milligrams per day for 1 to 2 weeks, followed by a slow tapering of 5 to 10 milligrams per week over 4 to 8 weeks. Anti-TNF therapies can also be used. So we do a scheduled maintenance therapy if recommended with any of the types. Also, we can also employ the anti-integrins as well as anti-interleucin 12 or anti-interleucin 23 antibodies. When do we do surgery, or when is surgery done for a patient with Crohn's disease? When the patient is presenting intractability to medical therapy, when there's an intra-abdominal abscess that cannot be cured or resolved by antibiotics, when there's massive bleeding, when there's symptomatic refractory internal or perineal fistulas, when there's intestinal obstruction. So this table is just a representation of the comparisons of Crohn's disease and ulcerative colitis, where we try to compare the two with respect to gender, ethnic group, risk factors, the presentations, the histological presentations, and then manifestations, and then management, because the two can be a bit confusing, but this can help to differentiate the two. This is a further diagram to differentiate the two. This is a histological endoscopical representation of pseudopolyps in ulcerative colitis and the cobblestone appearance that we see in Crohn's disease. These are my references. Thank you.
All right, thank you very much, Dr. Betty, for a great job done. The floor is open for questions, for comments. If you want to make use of the chat box, kindly just type in your question there. If you want to ask a question, you could also electronically put up your hand. I'll just unmute you and then you could go ahead with your questions. So whilst we are waiting for that, just some few inputs. Like I initially indicated at the beginning of the presentation, it is not all diarrhea with blood or long-term diarrhea, chronic diarrhea, that is HIV. Obviously, there may be more to it. It is not all diarrhea that is infective diarrhea. So we'll say that if someone has chronic diarrhea, that you've done your baseline test assessing for immunosuppression, and it is not, and you probably think that you don't know the cause, it will be good to refer appropriately so that then such a person will get expert management. The same way, if someone keeps coming with abdominal pain alternating with diarrhea and constipation, it is not all the time that it is typhoid or enteric fever that you treat the person, he comes back, you treat for typhoid again over and over. If it is not resolved, the right thing to do is to refer for further assessment and management. This patient had mentioned, the case I had mentioned at the beginning of the presentation. Unfortunately, we lost her on the endoscopy table. So immediately after the endoscopy, of course, the diagnosis of UC was made, ulcerative colitis. Certain is that, like you saw in Dr. Betty's presentation, looks like this patient traveling from Tamale to Accra, obviously with an increased risk of venothromboembolism through an embolus. So again, another key thing that we should take note of is although these people you find blood in their stool, we still anticoagulate them, prophylactic anticoagulation, very key. So despite the fact that you are seeing blood in the stool, it does not mean that wound, because what will kill them, like probably we suspected and in the patient that passed away, the venothromboembolism would. I don't see any hand up, and I think someone has, okay, so a comment in the chat box from Dr. Donatus. Nice presentation, Dr. Betty. Thank you, Dr. Donatus. So any questions, comments, or is all understood? Or everybody has been confused? It's one of those. I hope it's the former. Okay, so in the absence of any questions, we would want to thank Dr. Betty for a great job done. We'll be able to do this in about 40 minutes. And of course, we have some time for discussion. Fortunately or unfortunately, we don't seem to have hands up. Neither do we seem to have any comment. Okay, one has just come up. So, okay, so it's all just applauding you for the great job done. Someone as something said, thanks, Dr. Betty, and for Furonesis said, great presentation. Okay, so thank you all for your contributions, and thanks, Dr. Betty, for reminding us about inflammatory bowel diseases, which in our setting, we tend to think that they are not there, but they are, because we tend to treat the people as infective diarrhea or like immunosuppression, where it may not be. So let's kindly take note of this, especially the extraintestinal manifestations of both Crohn's and ulcerative colitis, especially in the females. If it is, let's get them in and then we get appropriate treatment. Hopefully next week we will come your way again with another presentation. We are grateful for the time that you've joined us. God bless. Take very good care of yourselves. Bye-bye.
Bye.